Hi, good evening.
Good evening, sir.
Hi,
How are
Joseph.
you?
Good evening. Good evening.
Good evening. How's everything?
Hi. I'm fine. It's going well here.
How's the Goa trip planned? Goa meeting?
Yeah. It is. And the program is almost ready. You might have
Mm.
got the. I think it is already been circulated in the WhatsApp group.
Yes. I'm
Yeah, but so the program is almost confirmed, including the ASCII speakers and the ACMR speakers.
Mm.
So
Which is the resort? Which is the resort?
Bogmallo Beach Resort. It's near the
Mm.
airport.
I see near the airport. Great. That's good
Y-
connectivity.
Yeah.
As I mentioned to you, my mother is quite sick.
Yes.
So
Yeah.
I've
Okay.
decided not
Take
to
care.
move out of Hyderabad.
Uh,
Next
okay.
year, she had a febrile neutropenia. We have
Oh,
temporarily decided to stop her chemo also.
okay.
She's not doing well. So a
Okay.
lot of medical emergencies in and out of hospital.
Okay.
So that's the reason. Just keeping a little low profile.
Uh,
Maybe, uh,
no
mm.
problem. I
So
can
anyway,
take
good
care
to
of.
see everything moving well.
Yes.
We are having our eco meeting in November here at Hyderabad. For
Okay.
those of you who are interested in picking up eco, 17th I will just send the brochure also.
Okay.
17th is the hands-on and 18 to 20 is the eco sessions. It's
Oh,
all offline.
okay.
I will just post that in the group.
Yes. Please. Yeah.
Big problem with funds after this new guidelines, IMA
Uh,
guidelines. Big problem getting funds.
No, it's going to be very difficult.
Very tough, very tough getting
Uh,
funds.
yeah.
How are you guys managing with getting sponsors?
Yeah, it is difficult somehow for this conference. Dr. Hemant able to mobilize something, so some basic thing. Otherwise, mostly it's going to be through the registration fee only.
Actually, through the registration only, yeah.
Yeah,
But
so
unfortunately, people register quite late. That is a big problem.
yeah,
And you have to pay the vendors and all quite a bit before. So that is a big thing we are having over here.
okay,
We have a
yeah,
lot of money to be given to the vendors much before, to make sure that everything is fixed.
okay.
So that is a big challenge with these new IMA guidelines.
Hmm. Yeah, this time all the no even the faculties, no, including all the executive members, everybody is no, paying for the conference, both the
Mm.
registration, accommodation, everything.
Registration and accommodation, yeah.
Yeah.
That'll go a long way in, clearing the debts.
Yes.
Mm.
Hello, Richa. Good evening.
Hello, sir. Can you hear me?
Yes.
Hi,
Can you
Richa. Good evening.
just
Good
check
evening, sir.
sharing?
One
Good
second.
evening, sir.
Hi, Pudi. Good evening.
Good evening, sir.
Ashita, good evening.
Good evening, sir.
Hello.
Yes. Yeah. Just can you share your screen and check your PPT?
Yes, sir. One second. Is my voice echoing?
No.
No.
Yes, it is visible. Can you go to slideshow mode?
Oh, it's not in slideshow mode.
No.
Oh, you seeing my screen, sir? This.
Yes. Including the
Okay.
next thing and the nodes, everything is in.
Now,
Yes. Yeah. Perfect. Yes.
proper.
Yes. Yeah, we'll wait for a couple of minutes. It's sharp 8 o'clock. 7 people are there. What about Dr. Vimal? Whether he'll be joining today? Only Wednesday he'll be busy. No? He has some other work.
Yes. Should I remind him?
Yeah, just yeah, he has joined right on time. Hello, Vimal. Good evening.
Vimal, good evening.
Just when we asked about you, you are there.
But he's not on time, he's late.
You have to give some punishment.
Dr. Elizabeth, good evening.
Good evening. How are you?
Fine.
Hello, ma'am. Good evening.
Hi, good evening.
Good evening, ma'am.
Good evening. Are we waiting for some more people?
Yeah, maybe a couple of minutes we'll wait. So then we'll start. I think Dr. Priya Chutkar will join.
Hey guys,
Hi, Vimal. Good evening.
good evening.
Yes. So we are just asking
Good
about you
evening, Vimal.
now because only Wednesdays you will be busy. I thought not today you will
Yeah.
join on time.
Wednesdays are, thank you for readjusting it to Thursdays. That's very useful. Thank you.
Yes.
Vimal sir is busy most days, sir.
Yes, Pudi, since you left, we've become very, we have to work now. That if you had stayed back, it would have been nicer.
Now, if he is in Narayana, then you will be the only boss. No, now he is now become his own boss now in his place. So
Rajesh, he was boss here also. I also he was the boss. Chumma, I was for name, I was the boss, but he was the true boss. He's like the
Sounds
Rajni.
familiar.
He's becoming the Rajni of cardiac imaging. Universal boss he's becoming.
Sir, I must have kept quiet, I think.
yeah, I think we'll start. Good evening, all. I welcome you all for this month Journal Club. And today we have Dr. Richa Kothari from Narayana Irdalaya, and she is going to discuss a very important topic. It's the diastolic dysfunction, so also known as heart failure with preserved ejection fraction. And we are now hearing about this for quite long period, and this one area where it is neglected by many people, even among the cardiologists. I think so there are still a lot of debate about the importance of the diastolic function and its relevance, and definitely the imaging gives a lot of additional information in assessing the diastolic function. And today Dr. Richa going to discuss about this topic. I think she is going to compile a couple of recent articles and mainly some of the review articles, and she is going to present this. Yes, Dr. Richa, I can start.
Thank you, sir. Good evening, everyone. I felt like this was a good topic to take for today's class. So hopefully we'll have a very interactive session. So before I begin, I just wanted to know if any one of you all report diastolic dysfunction in your CMR reports as of now.
I do occasionally.
Yes, I also do.
Okay.
Occasionally.
Yes, not confident enough. What I do is I often use phase contrast at the mitral valve level and obtain a curve E by A ratio and the deceleration time and everything. But that doesn't come out very well in many patients. So if it comes out well, then I use that data, but otherwise I don't use it.
So I think
We mention only when the volumes are decreased, end diastolic volumes, if they are less, especially index values, we just make a comment on that, but don't actually report the diastolic dysfunction.
Indexed ventricular volumes, if they are low, you make a comment.
Yeah, comment on the decreased volume. Usually they tend to have diastolic dysfunction.
So essentially what, like they said, in restrictive cardiomyopathy, especially if we have a prior history, or if it looks like,
advanced HCM also,
on 4 chamber.
But one thing I find is that the index volumes that we use from that European journal, many patients in my place have a low value. I'm not sure if I can call all of them are having diastolic dysfunction.
Because with combined with
don't have an index.
atrium, I mean, both in combination actually, with dilatation and decreased LV volumes.
But essentially the extent of reporting essentially remains the E by A ratio by mitral valve Q flow and left atrial volumes. That's what we mention as of now, right? So today this topic has a lot of recent review articles. In the last 2-3 years in JACC and JCMR itself, I found at least 5-6 articles just on this topic. So let's see what we've not been doing or what more we can do. So just a very brief overview, because for me it was very confusing. What is diastolic dysfunction? What is HFpEF? We are both the same. Is there any difference between the both? So diastolic function, as we know, is just all physiological processes that allow LV to fill with blood. So the entire diastole, the entire process actually begins in systole, where the energy is stored within the myocyte and the torsion of the fibers of the myocardium. So as soon as systole ends, there's an abrupt untwisting of the fibers. So this lowers the pressure in the LV, and there's a suction effect, and the mitral valve opens and blood flows by suction or negative pressure gradient into the LA till the LA and LV pressures equalize. And then there's a final component of ventricular filling by atrial contraction. So derangement in any of these components during diastole can cause diastolic dysfunction. So we saw the components of diastole. So any problem in any of these components will cause diastolic dysfunction. So what are the potential disruptors? So the systolic dysfunction can also cause diastolic dysfunction. And if the rapid untwisting and relaxation doesn't happen, that can cause diastolic dysfunction. So when could that happen? In case of LV hypertrophy, ischemia, or dyssynchrony, or infiltration, constrictive pericarditis, and RV overload could also cause diastolic dysfunction. If atrial contraction is not effective, that can also cause diastolic dysfunction in cases of atrial fibrillation or atrial systolic failure. So how do we measure diastolic function? The gold standard is invasive. It's by cath, where we measure actual intraventricular pressure measurements and end diastolic pressure and ventricular stiffness by using ventricular volume measurements. However, this, as we know, it's not practical for daily life. So various echo parameters have been developed. So this is an algorithm for diagnosis of diastolic dysfunction by echo, published in JACC in 2017, where basically it takes into consideration left atrial volume. And so if we see this, it basically takes left atrial volume if it is high or if it's raised. Then in cases of E by A, then they look at E by A ratio, the deceleration time, and E prime. So E prime is basically a tissue Doppler imaging characteristics where the velocity is measured in the myocardium at the level of mitral valve, usually septum, or if it's on the lateral, near the lateral annulus, it will be a lateral E prime. So based on all these values, on echo, they divide it into grades of diastolic dysfunction as normal, grade 1, grade 2, and grade 3, based on E by A ratios, E prime, and left atrial volumes, and deceleration time. So that's how they diagnose diastolic dysfunction on echo. So on MR, we can replicate some of these parameters. We can have left atrial volumes we can take E by A ratio by taking a Q flow at the mitral valve. E prime also we can take by taking phase contrast in the myocardium, whether septal or lateral. But we do it at our institute also, but I don't think our values are as accurate as echo. So now, what is HFpEF? According to the AHA-ACC definitions, heart failure with reduced EF is any heart failure with EF less than or equal to 40. If it's 41 to 49, it's heart failure with mildly reduced EF. And in case of heart failure with more than 50, it's heart failure with preserved EF. So diastolic dysfunction is a leading cause of HFpEF. It is important to diagnose HFpEF because the EF will be maintained. So heart failure is not just low EF. There's also a HFpEF where the EF will be preserved. So how is it's only diagnosed by evidence of increased LV filling pressures. And it has a high prevalence. Almost 50% of heart failure cases are HFpEF, and they are associated with adverse prognosis. So that's why the diagnosis of diastolic dysfunction and HFpEF becomes important. Just an overview of the American Heart Association stages of heart failure, so that the next slide will show at what stage we can diagnose what. So according to the AHA, stage A heart failure is just at risk of heart failure. That means the patient doesn't have any symptoms of heart failure, and there are no abnormal biomarkers, and there's no abnormal structural or functional heart disease. Just patient is at risk. So patients with hypertension, diabetes, obesity, cardiotoxic agents, genetic variant for cardiomyopathy or family history are all stage A heart failures. Stage B is still pre-heart failure. That means patient may not have signs or symptoms, but may have one of these features, like may have evidence of increased filling pressures or some structural heart disease or some increased biomarkers. Stage C and D are symptomatic heart failure. So as soon as the patient becomes symptomatic, it's a stage C heart failure, and D is advanced heart failure. So now if you want to diagnose heart failure at the earliest, there was a review article in JACC in 2020 where they looked at myocardial mechanics in patients with normal EF as well as those with diastolic dysfunction. And what they saw was this kind of picture. So what is happening is strain is one of the first parameters to reduce. So subendocardial dysfunction is commonly present in stage A. So this manifests as a reduction in GLS. And this may even present prior to onset of LV hypertrophy and remodeling. So in stage A, when the patient is just at risk, we can see that GLS would probably be the first parameter to reduce. As we go on to stage B, heart failure, there is myocardial hypertrophy, especially in the subepicardial region, which occurs in an attempt to compensate for this subendocardial wall stress and to preserve EF. So these patients will have preserved EF, but will have the beginning of LV hypertrophy. And we can see that the parameters, what we usually see on CMR, like LV hypertrophy, fibrosis and all, are all at stage D, which is advanced heart failure. So as we see that strain is one of the first parameters to be compromised. So this was another study published in JCMR, where they did CMR feature tracking and in HFpEF patients, and they correlated GLS with the gold standard, which is the actual invasive diastolic functional indices they compared. However, this had a very small subset of patients. They did this study in only 18 patients. But what they found was that in HFpEF patients, the invasive diastolic functional index of tau, that is of LV relaxation tau, strongly correlated with all the strain parameters. And they concluded that CMR feature tracking LV GLS independently predicts invasive LV relaxation index tau, and hence CMR feature tracking with ECV can be used for evaluation of diastolic dysfunction in patients with HFpEF. So this is one of the articles which kind of puts it all together for us, where in JAC in 2020, where it is basically on CMR in evaluation of diastolic dysfunction and phenotyping of HFpEF. So they evaluated all possible ways we can evaluate diastolic dysfunction on MRI. So in MRI, what we can do is we can calculate left atrial volume. We can also calculate transmitral velocities using phase contrast. So we can have E/A ratio. We can measure LV mass and hypertrophy. Feature tracking or strain can be done on MRI. We don't need to even do additional sequences for this. Myocardial tagging can also be used to determine strain. And last but not least, we also have tissue characterization sequences like T1 and ECV mapping, which will tell us about the early predictors of myocardial diseases. So they basically evaluated the strengths and weaknesses of each of these processes by cardiac MR. So suppose, so LV mass and hypertrophy, CMR is very highly reproducible and there is no geometric assumption like in echo. However, echo is more widely available. Another parameter is LA size and function. So CMR gives very accurate LA volumes. However, they are larger than echo because in CMR, it will basically cover the entire this thing and it is not operator dependent. Another parameter is tagging, which will directly measure the strain. However, it's an older sequence with longer acquisition times. Transmitral or pulmonary vein flow velocities will directly measure the blood flow, and not only through plane, but also in plane blood flows. However, the temporal resolution is low compared to echo. Strain imaging, as as we saw, it's a very robust marker for subclinical or very early LV dysfunction. And we don't even need to acquire additional sequences. It will be on routine CMR sequences. We just need to do post-processing. However, that post-processing is time consuming. CMR is the only modality which provides a direct measurement of fibrosis by ECV and T1 mapping. So it's a very novel and good marker with more and more emerging data on it. However, more validation is required. This was another similar study in heart failure reviews where it just explained the utility of CMR in diagnosis and management of HFpEF. So it is essentially the same where we can use bioventricular volumes, mass, wall thickness, systolic function, flows, along with transmitral pulmonary venous velocities and tagging and tissue characterization. This is another study from JCMR from 2021, where they had a slightly different approach for HFpEF. And they said that coronary microvascular dysfunction has been proposed as a novel mechanism for pathophysiology of HFpEF. So they decided to measure a phase contrast of the coronary sinus. So, so they decided to use coronary flow reserve as a marker of coronary microvascular dysfunction. So how did they do that? By using phase contrast of the coronary sinus. And what they found out was that CMR derived coronary flow reserve was significantly lower in patients of HFpEF who had adverse events compared with those who did not have. So if I go slightly into the method of how they did it, they took phase contrast Q flows of the coronary sinus. And the myocardial blood flow was calculated as coronary sinus blood flow divided by left ventricular mass. And the CFR was calculated as myocardial blood flow during stress and rest divided by that of rest. Now we saw till now how CMR can help or can add on to echo for diagnosis of diastolic dysfunction and HFpEF. But another important utility of MR in such scenarios is not only to just diagnose HFpEF, but also to recognize other alternative pathologies in patients who are diagnosed as HFpEF, like coronary artery disease, HCM, constrictive pericarditis. There's a study by Kanagla et al. Which found that almost 27% of these patients turned out to be alternative pathologies. So CMR helps, suppose HCM, for example, differential diagnosis of HCM, CMR is very useful in telling us that, yes, this is HCM. For that matter, so as we look at the differential diagnosis, almost all of these differential diagnoses, we can confirm with CMR. Whether it's HCM, constrictive pericarditis, valvular heart disease, coronary artery disease, we can use stress MR. So to conclude, diastolic functional assessment is the cornerstone in the work of HFpEF, and it is as important as systolic functional assessment. Echocardiography is the foundation for assessment of LV diastolic function. However, CMR can be used in multiple ways. It is very good for functional assessment, whether it's atrial or ventricular. It's also very good for LV mass and hypertrophy assessment. It provides early markers for detecting myocardial disease. We can use strain using the same sequences. We can do tissue characterization using T1 and ECV mapping. So not only that, as I discussed, CMR can also add value in the diagnostic workup in unmasking alternative pathologies, like in detection of coronary artery disease, microvascular dysfunction, HCM, infiltrative diseases, and constrictive pericarditis. Thank you.
Thank you, Dr. Richa. So yeah, it's a very important topic, and yeah, you've given an overview of different aspects of assessing diastolic function and the role of cardiac MR. Anyway, it's open for discussion. Yes, Dr. Vimal, your comments, please.
Richard, do you want to be a bit more concise on what I think I would have liked to have seen in the conclusion, you telling us these parameters is what you should see and you should call it HFpEF or diastolic dysfunction in the conclusion. So tomorrow, if we are reporting a cardiac MR and we are looking for diastolic dysfunction, what do you think we should look for?
So I think the first thing I would probably be normal EF, systolic EF. Once we have that and a dilated left atrium, I would probably start thinking further that could this be diastolic dysfunction in these cases? Because the problem is we don't do like strain we would do in all patients. T1 and ECV mapping we do in all patients, but we would not do mitral valve flows in all patients. We would not have the E/A ratio or this unless we make it a protocol. That would be a difficult this thing to put in our daily protocol.
I think in a manner of speaking, I think for all of us, when we talk in terms of diastolic dysfunction, it becomes important that, which we also don't do very regularly, is to look at the LA volume. I've seen some of us have started reporting LA volumes consistently in their reports. That would be a very good marker to talk about whether the LA is dilated or not. And if we see LA being dilated with a relatively preserved systolic function, then we have to think about diastolic dysfunction. So adding a strain value would be a good parameter, and maybe the E/A ratio, if we have that, would be the second good thing. That would be my comments. I do know that most of us do not have necessarily the strain values easily available for us as a software. But that's a question I want to ask others in a little while, just to get an opinion. But I think LA dilatation should be the first marker. Without LA dilatation, I wouldn't entertain a diastolic dysfunction. But LA dilatation, once we see that, then we have to start looking at other parameters, which could be strain, could be E/A ratio, and the deceleration time in that.
Yes, Vimal, I think maybe we can dissect one by one. See, suppose if you are talking about the LA measurements, there are many ways are there which we usually do only the LA area measurement on a 4-chamber view. That will be a rough, say around 25 centimeters square. We'll take it as a cutoff. Anything above 25 centimeters square, we'll call it as an enlargement. So, what is your call? When will you call it as enlarged? Are we doing the cross values, both the diameter and the area, or volume? I don't think anybody will be doing it regularly.
No, I think just one step behind that, Rajesh, is a question of do you take the LA end diastolic volume or LA end systolic volume?
Because maximum size, basically. So that means end systolic.
And ventricular end systolic.
Ventricular systolic, yes. Yeah. Just before the mitral opening.
Correct. I think the circumferential area is much more practical to be done, and it is much easier to be done. Depends on the software. I think Ashita probably also has NeoSoft. I'm not sure, but I've been told NeoSoft gives a volume fully.
Yeah, but
is that correct?
Yeah, we have, but then we haven't used it for LA volumes. But yeah, it does. It's actually.
I think it also gives ejection fractions also. left atrial ejection fraction. Some articles do mention about that LA ejection fraction as well as one of the markers.
So what about the LA volumes from 4-chamber and 2-chamber views?
Yeah,
Comparing
actually,
both-
there is an app to calculate that for the which is freely available called CMR
I think
calculator.
even the Philips ISP that we have gives us an option to contour the LA in 4-chamber and the 2-chamber views, and it gives us the volume of the LA.
Okay.
So yeah, there is a biplane method with the Philips ISP which does that, where you can do the LA volumes. I think LA volume is a better marker, but if you do not have, then the circumferential of 25, what Rajesh is mentioning, is actually quite good. We can agree upon that and progress on that in that. So that would be the first marker I think we have to look at.
Vimal, even going further, I'm also using the same Philips thing. Indexing it to body surface is even more important. That gives you the true, character of the initial part of the diastolic dysfunction. So getting the volume, we do 2C and 4C area length method, and then we index it to the body surface area. That gives a really better picture than just a simple volume, and we find it much superior to area, because area can be sometimes variable. But the volume and index to the body surface area, I would agree with you, is a true gateway into looking at diastolic dysfunction when you have a patient with a fairly preserved systolic function. Any poor systolic function, it really doesn't matter beyond a point.
And what's your cutoff, Juan? Juan, what's your cutoff for the volume?
Yeah, indexed is around 22 to 24 indexed, and around 60 we take for the normal volume. Anything above 60, then we call it. And so we also make sure this patient doesn't have a significant mitral regurgitation, because that will again influence the LA. The patient could have a normal diastolic function and a significant MR. So you must rule out a mitral valve disease significant and a significant mitral regurgitation before you make that comment about the LA volume. I think this is very important when we are looking at it, because mitral valve disease can have a normal ventricle size in the early stages, but you don't want to be talking about diastolic dysfunction in the presence of mitral valve disease. So that I think is important to convey.
I think that's very important, and I think it's purely dependent on the softwares, because we have seen some demos of some of the softwares where even without a click, it gives us the volume, a complete volume. And in that scenario, volume becomes much more nicer. While there are some software which will only give you the area, and then you don't have an option but to use the area, just like what Rajesh said, what Bhavna is also saying, that would use the area.
Vimal, but you can add the length also. If you look at the 3-chamber view, because this is what we do on echo routinely. The higher end softwares may not be there, and most of the echo machines and the peripheral setups. So what we routinely do on echo is that we take the 3-chamber view, and there at end systole, perfect end systole, you can just cut it at right angle at the mid wall, and then you can do a perimetering of the LA. And of course, area into length, you get a rough volume. For those people who don't have the software, there's a rough idea that you can get. And you make sure you do that on the 2C and 4C, and you can take the average. So that is one way of doing it if you don't have any kind of software support. And it does give a fair idea.
Absolutely.
Adding to that, I just shared a link of an application iOS app basically on the WhatsApp group. I use it routinely in my daily work whenever I need to do this calculation. It gives all the indexed volumes as a reference range as well. We have to enter the matrices which Dr. Johan just mentioned: 4-chamber area length, 2-chamber area length, and it will give us the height weight of the patient. It will give us the index values and whether it is the normal range or not. And it's also gives us gender-based values as well as a reference.
When you say the length,
length in the
When you say the
four-chamber
length
view.
of the atria,
Yeah.
is it from the roof to the valve or from the walls, the septum to the
It's AP,
opposite?
four-chamber view, long axis, AP dimension actually. So it will be from posteriormost part of the left atrium to the valve, AP dimension.
Okay.
And it's along its long axis.
It will be the long axis, whichever view you're
along
looking
the long
at,
axis.
the long axis.
Yeah, long axis. Yeah.
Right.
It can be either two-chamber or four-chamber. It's one length. It needs two areas and one length, basically.
Richard, one of the papers that you showed a diagram on a four-chamber. The area was mapped out, and in the same four-chamber, a length was drawn. It was not a four-chamber and a two-chamber view to calculate the volume. Is that how that journal was saying you should do it?
Can you show that slide, Richa?
Rich, are you there?
Yeah, she's there.
Sorry, I didn't
Muted,
realize
yes,
I was
yes.
muted once. Can I
Yes.
share my screen?
Why is that I'm only switching on my camera? Why are you guys all hiding behind something?
We all want to watch you.
I'm
So
keeping
you-
it on,
you
so
seem to-
encouraging people to switch on their camera just to see everyone. But even then,
So
people are.
you seem to have the perfect spot for webinars, sir. The room looks superb. And if I switch on my video, you'll just see my kids' daughter's underwear hanging behind my head.
Is it raining Pooji there?
Yeah, it's
raining diapers.
Yeah, it's raining heavily here in Coimbatore.
Okay. Because that's a scene in every home when it rains outside.
Yeah.
What
God
is
has a special office now.
what is your son doing, Ashita?
He's fallen asleep just now.
I've just sent a thing of how to do the link. Just have a look.
Yeah, this is how I do it. Like the one that's there in this figure that Richa has shared.
Oh, is it drawn here?
Yeah, here the one that
Yeah,
Richa has
yeah.
shown. Yeah.
Yeah, so it is on just a four-chamber view. There is no two-chamber added on to this. Is this how you do it?
No, ma'am, for volumes, we'll have to take both 2-chamber and 4-chamber. And
We take both the 2C and 4C both.
Okay, so
Richa, we can't see your screen.
oh, I am.
We are able to see.
Yeah,
Probably you should just scroll it. Just scroll through the.
Can you all see it now?
so
Yeah,
they've
we can see
drawn
it,
the area
Now we
and
can.
they have drawn one vertical line from the roof to the valve. What is that line?
That's the length.
So
That's the length.
So they've drawn both in the same, no?
Ma'am, that's just the pictorial. So in the article, they've not mentioned one particular. So I'll just read out. Basically, they say that LA volumes using CMR can be measured in either long axis or direct short axis orientations. Similar to echocardiography, LA volume can also be derived from area length method or this biplane method, which Dr. Yuan just said. And it only says that it should be measured in end ventricular systole immediately before the mitral valve opening.
Okay. All right.
So it's basically a review article which has just in JAC, which has just gathered all the studies and it's just giving a compilation.
Yeah.
So it doesn't
It's an
suggest a method of
artist.
it. Yeah.
Yeah, it's an artist's drawing. So
Yes, yeah, so we got some amount of discussion on this. So moving forward, what about the mitral inflow PC? Yeah, I think everybody will be doing it, and we'll be seeing some curve. And but how many of you are actually really confident in reporting that and the additional features other than E wave, A wave? Like deceleration index, do you have any softwares for that? Anybody having additional software? How will you use this?
So Rajesh, the Philips software gives us that. The simple Q flows, we are able to do the E by A ratio. We are able to do the deceleration time. That's not a problem. The problem we face is, if you're not supervising your studies, and we don't do it as a routine. The mitral flow planimetry imaging, we don't do it as routine. We tend to do it in constrictive, restrictive physiology kind of patient, but otherwise we don't do it routinely. But whenever we do it, we get the E by A and deceleration time we do get.
Yeah, and in that mainly, how will you differentiate the pseudo normalization from abnormal?
That is always I think when you reach that pseudo normalization stage, you're going to be having trouble with that. We do look at the deceleration time to help us a little bit. Often it does not help us, but DT is the one which we can help in the differentiation of that.
Yeah, I think pulmonary vein PC is supposed to be helpful to differentiate, but I don't think we'll be doing it regularly.
So we looked at the right superior pulmonary vein, especially because that's meant to be very specific, especially for diastolic dysfunction. And it's meant to have very nice patterns, which seem very nicely shown on echo. We didn't get very good patterns on MR flow metric.
What?
Just like
Velocity. Sorry.
Just like the E by A ratio, you have this E high and A going down. They have a similar one. I don't remember the name. They've got A1, S, etc. It's a different pattern of flow based on, and that pattern changes with the diastolic dysfunction. So I will show that in a second. I think I'll try that, bring that pattern up somewhere.
What velocity do you use?
For the mitral valve or the pulmonary
veins? Mitral.
Mitral valve, we start with 60. Venk is 60.
Yeah. Johan, I don't know if you saw the question Bhavna put up. Does diastolic dysfunction make a difference to management? Does diagnosing it make a difference to management?
Yeah. Actually, if you look at it, as I said, when we're looking, and this is specifically, we're looking at heart failure. Our traditional heart failure has always been HFrEF for the most part, and that's where all the foundational drugs have come in. We don't want to look at diastolic dysfunction as such when the patient already has a HFrEF. We have a systolic dysfunction and you deal with it. The diastolic function actually comes in, and it's a very important parameter when you have clinical signs and symptoms of heart failure, but in normal ejection fraction defined as anything more than 50%. That is the time we actually start looking for diastolic dysfunction, not otherwise, because every systolic dysfunction, more or less, has an accompanied diastolic dysfunction. This is a well-proven thing. Now, echo is a very robust and very good technique for diastolic dysfunction, either at the pulmonary vein level or at the mitral valve level, or the tissue properties at the both walls, lateral and septal, I think, which has already showed that. So very robust, very good data, very nice and clean data. And with my little experience, the MR data on this, and Vimal can correct me, has not been really good because, you have to be there, you have to use the right VEC. Sometimes it's not possible. And it's not something that we are doing in and out, any technique to do well, you got to be just doing it day in and do, just like we did our volumetry and everything. So there's a little problem in the technique. But what is important today is that HFpEF has become a big thing now. And there are now drugs, the SGLT2 inhibitors are well poised, and the data is very robust for both the drugs, EMPA and DAPA, for improvement in quality of life and also a mild mortality reduction in the HFpEF space. So there is now going to be a big race to identify these people. And these are generally women, they are elderly, they are more diabetics, more hypertensives, and they have AF. So this is the general population we see with HFpEF, and AF is a very predominant thing. And we know that AF is a big spoiler for both CT and MR. So getting that clean and good data in a very consistent fashion, I believe, is going to be difficult. Vimal, your thoughts?
I agree. I think, see, the diastolic dysfunction is something very, very important, and we have to start looking at it. There's been a long period of inactivity, at least on my part, where I have said, echo is better at it, get an echo done. Why are you asking us to look into it? But more and more, I'm realizing is that there are patients who are referred to us with typical heart failure symptoms, and we are not finding any ejection fraction in the range of 54, 55, etc. And there is very aggressive treatment regime available for these patients. So we have to start looking at it. That's why I asked Richard to begin with, give us a very practical approach. And the practical approach is LA volumes. I think that's something we have to do in patients who have observed systolic function. Just do the LA volumes first. And we should all go towards strain analysis and the E by A ratio, etc., that we can see in, because I think this is going to come, this is going to stay, and it's very important that we get good at it. Just digressing 1 second and sharing, this is what I was telling you is the pulmonary venous flow. Similar to what we see in the mitral valve, the atrial relaxation and the atrial contraction time, the E by A. In the pulmonary vein, this is a normal rhythm, where this is basically the atrial diastole, early passive filling. This is the later passive filling. And this AR is the flow where there is atrial contraction. And depending on the grade of diastolic dysfunction, you can see this also changes. So the pseudo normalization that we see here will still have a very high peak of the atrial. So it will make it very easier for us if we do this to differentiate the pseudo normalization that Rajesh was talking about. This pattern I'm not getting. That's the problem for me. I am not able to replicate this pattern on pulmonary venous flow in MR.
Yeah, Vimal, just to share my experience also both on echo and MR, pulmonary veins are not easy, even on the echo. Visualization them is a little difficult, getting that small, point. So what we have done is we have just leapfrogged this technique, and we directly do the mitral valve and the tissue. And if you just show your slide again, if you don't mind, you will clearly see that the tissue Doppler has got a nice meaty ventricle. And remember, most of these patients have a thickened ventricle, generally, as a rule. The HFpEFs have got good ventricles, they've got good thickness. So if you look at the tissue Doppler imaging for the same image, that's the third image, where you are confused that the E is more an A, is it normal or is it pseudo-normal? And you will clearly see that the tissue Doppler makes a very categorical change, where the AM is now more than EM, which was not the case with the normal patient. And because it is a much more meaty portion, you can put that point there. Just a practical thing in my practice, I've stopped looking at pulmonary flow completely, and we just look at mitral valve level and tissue Doppler, and we get our results. And of course, the last one is very easy because the E wave has to be at least 2 times that of the A, and becomes very easy for us to distinguish that from the first one. But it's the third one which is the source of trouble. And if you just do a tissue Doppler, you will find that the AM is much more than the EM, where the EM is very prominent in a normal way. So that's a simple clue, a trick I do in my regular practice. I've just stopped looking at pulmonary flows.
Vimal, the mitral valve flow that you do, is it 2D or 3D?
It's a simple Q flow. We don't do 3D. No.
2D is supposed to be quite inaccurate. No?
You have inaccuracies because it's not a very rounded structure, and the mitral valve will keep moving up and down in that. So if your breath hold is also good, you will have inaccuracies, but you have to make the best use of what you have, basically.
And do you try phase contrast for tissue characterization?
We've tried, not very good. So the E by E prime, which is what Johan is talking about, which is the tissue Dopplers, we are meant to be able to do it in Q flows. We've not been successful.
Johan, doesn't atrial fibrillation also cause LA dilatation? Is that a concern?
Yes. So as I said, the first sign of diastolic dysfunction is an LA dilatation. And I think it is very important in this journey to get the LA dilatation right. And it's the volume, and it's the volume over the body surface area, which is, that is what is really looked at in all the major publications and papers, not area, not volume, but it's volume over the body surface. So we need to get that right. And that is fairly easy to get it if you do it consistently. Now, because most of our patients have AF as a rule, patients with HFpEF are predominantly with AF. My experience with getting the Dopplers have been quite poor over the last couple of years. And I don't expect me to be doing it better because most of these patients come into our lab with AF. So it's going to be a little difficult. I believe we need to look at LA volume, register that, because that is going to be a good thing to look at these patients prospectively. LA volume by MRI is far more accurate than what we can get on echo, and that will be a good pointer to see these patients forward. We have all the other techniques which Richa has already talked about, which will help us to characterize these patients, not so much for making that diagnosis, because remember, the diagnosis also is a clinical diagnosis. It's assisted by BNP, elevated levels of NT-proBNP. And really nowhere in the guidelines do you need either an echo or MRI, support to make the diagnosis. So internationally, the diagnosis of HFpEF is based on clinical, and it's based on the NT-proBNP. But we are here just not only to support the diagnosis, but to prospectively keep watching these patients down the line and see how they improve with GDMT, which is guideline-directed medical therapy. And I told you that there are 2 drugs that we are currently using, which have got good benefits. So prospectively seeing these patients, I believe MR and echo has a role. So we should pick up things which we can do easily. And I believe Vimal, struck the nail on the head by saying that LA volume is something we must focus on, because it is a very reproducible thing. It's easy to do, and we need to do it consistently. And for those of us who have the other softwares, we can also look at that. But pick those which you can do easily, which are consistent, and which you can be accurate, and replicate that time and time again. And that's where you will really get that database, which also includes obviously the ECVs and the mapping, T1 mapping, which are also important diastolic dysfunction or HFpEF parameters.
So I think for us, kind of to conclude how we can use it in our daily life, I think first thing, normally EF patients, if we see dilated LA, or at least if we subjectively feel LA is dilated, we should definitely do LA volumes. Best method is, as Dr. Johan said, biplane, using the biplane method in 2-chamber and 4-chamber, getting the LA volumes. And then with those of us who have the availability, we should give T1 mapping, ECV, and strain values. Is that correct?
Yeah, I think Priya has been doing some work with LA strains in cardiomyopathy. If she's there, she can share that. We saw some of them in some of our meetings with the cardiology groups. So strain of LA which I believe is fairly reproducible, and the software is available, I think is a very robust way to pick up diastolic dysfunction very early, and it does not involve some of the intricacies which we have to do with these flow, Q flows, which I believe, unless you're very experienced and you have a lot of time and you have a lot of experience, I think these are going to be essentially flawed. So I believe, I believe that we can leapfrog onto strain, because these can be done, even retrospectively. If the software is there, we can apply it on the images that you have. And both for the LV and the LA strain, I think these are very robust images, easy to replicate, which is the most important thing here, along with the LA volumes and the ECV and the T1. I think these three, we should consistently do in as many patients as we can, and we'll obviously build up that expertise.
Yeah, so I think good discussion. So anything else? Any other comments?
I think let's all start doing LA volumes, and when we meet in Goa, we'll talk about our experience about what that has shown up. That may be a good thing to talk.
Yes. Okay, so if there are no more queries or any comments, so we'll wind up. Thank you all. I thank Tricha for such a wonderful presentation. So we'll meet next month. I think probably another couple of weeks we may be having a executive committee member meeting. We have to discuss our regarding the Goa meeting. So please watch for the instructions by our President Dr. Hemant. Okay, good night.
Thank you,
Good
sir.
night, all.
Richa, that was great.
Good night.
Good night, everybody.
Thank
Vimal,
you,
give
Richa.
her a day off.
Yeah,
I
please
need
give her
a
a
day
day
off. Thank you.
We
Bye-bye, guys.
don't want women to be too stressed. Don't give her a day off.
Bye.
Bye. Bye, sir.
Bye, guys. Good night.